across the world. We are so happy today to have a presentation on overview of dermatological emergencies. And today our facilitators and also the panelists will be Dr. Karen Waithera, who is a Senior Medical Officer at Kenyatta National Hospital, Othaya, and also who has a postgraduate diploma in clinical dermatology. Our moderator is going to be a consultant dermatologist, Dr. Jacqueline Cavete, who is also the head of specialized medicine at Kenyatta National Hospital, Othaya. So feel welcome, and any questions, just for housekeeping purposes, kindly let's post our questions at the chat box. We'll be able to answer them as we move forward. If you have any questions, you can also raise your hand. You'll be given opportunity to ask. Let me take this opportunity to welcome Dr. Cavete to take us through this, and welcome Dr. Karen.
Thank you very much, Ken, for your part in organizing this. And thank you to all the participants who are joining us from Kenya and from around the world. So Jacqueline Cavete, so dermatologist at KNH-UoN, and I will be moderating the session as well as being a panelist. So I would like to introduce Dr. Karen Waithera, who is a medical officer with interest in dermatology. She also has a postgraduate clinical dermatology, and she will take us through this presentation, which is quite important for us in our daily practice. So Dr. Karen Waithera, you're very welcome. You can start your presentation.
Okay. Thank you, Dr. Cavete and Okinda, for your introduction. Good afternoon, everyone, and happy International Women's Day. So our presentation this afternoon is on dermatological emergencies. And our objectives for this afternoon will be to enable all the people who've attended this session to recognize any potentially severe cutaneous eruption. And in case of skin adverse reactions to medication, that they can be able to identify any possible culprit drugs. And then when it comes to all dermatological emergencies, that we can be able to intervene early before any severe adverse effects set in or before mortality happens. So I'll begin by showing a basic lesion guide. I hope you can see my pointer. So we'll start with papules, which are basically elevated lesions that are superficial on the skin, and they measure less than 0.5 centimeters. A bigger variant of that would be the nodule, which is an elevated lesion measuring more than 1 centimeter. The colors may vary, they don't have to be the color that I've displayed here. Then we can talk about the macule, which is a flat lesion with discoloration of the skin, and it measures less than 1 centimeter. When it's more than 1 centimeter, we call it a patch. Then fluid-filled lesions, we have vesicles, which is a fluid-filled lesion that has free, clear fluid. When that fluid inside the lesion is pus, we call it a pustule. When it's bigger than 1 centimeter, we call it a bulla. So we basically covered all of this except a plaque, which is a superficial elevated lesion that is flat-topped. Then we can go to a wheal, which I think most of us have seen, especially in allergic conditions. They're edematous and they're transitory. They usually resolve in less than 24 hours. Then we have scales, and then we have crusting, which is dried serum or exudate on the skin. We have fissures, which is basically a crack or a split on the skin, mainly due to a lot of skin dryness. And then we have excoriations, which are mainly due to scratching. Erosions, which are secondary lesions that we see when there's partial loss of the epidermis. When the loss of the epidermis is full, we call it an ulcer. Then we have lichenification and scarring. So on to dermatological emergencies. They're quite uncommon, which is why dermatology is a good specialty generally, but they have high mortality if they're not recognized early and interventions are instituted early. So if we were to classify dermatological emergencies, they'd be as follows. We begin with infections, which I've listed down below. They can be either bacterial or viral. So for the bacterial infections, we have staphylococcal scalded skin syndrome, necrotizing subcutaneous infection, meningococcemia, and toxic shock syndrome. For the viral ones, we have eczema, herpeticum, and varicella infection. Then we have drug reactions. We have tumors, we have autoimmune disorders, exfoliative dermatitis and its complications, and skin failure syndrome. We begin with staphylococcal scalded skin syndrome, which is caused by Staphylococcus aureus, which produces exotoxins. These are exfoliating A and B. And who is likely to get staphylococcal scalded skin syndrome? It's someone who has reduced renal toxin clearance or is unable to produce neutralizing antibodies to the toxin. So the people who are at risk are newborns, infants less than 2 years or even up to 5 years, adults with renal failure, and those with systemic immunosuppression. How does this condition present? Presents with fever, malaise, sore throat, and tender skin. So whenever you see tender skin, that's a red flag to you. It's not itchy, it's painful skin. And then mild facial swelling, and then they have this fissuring around the oral cavity and around the ocular cavity. And then they'll also have crusting. So I'll show you pictures on the next slide. But generally, flexural areas are more affected, but the mucous membranes are not usually involved. And Nikolsky sign is positive. So this is a demonstration of Nikolsky sign, which is seen in a number of conditions, of which one of them where it's seen almost all of the time is staphylococcal scalded skin syndrome. So you apply lateral pressure at the edge of the lesion and the lesion expands. And then here is an image of an ulcer with surrounding erythema seen in staphylococcal scalded skin syndrome. And as you can see, this is a flexural area. Also, this is the neck, another flexural area. And in this case, it's more extensive involvement. We can see erythema and we can see multiple erosions. So if you identify staphylococcal scalded skin syndrome, how do you manage? Number one is that you have to know it's a clinical diagnosis. A biopsy will not really help you in diagnosing this patient. When you do your complete blood count, most likely you'll see an elevated leukocyte count. Other than that, treatment is by systemic antibiotics. So you can choose to either do oral therapy or IV therapy if the patient is severely sick. For oral therapy, we can use cephalexin or flucloxacillin, also depending on the local culture and sensitivity pattern. Then you can consider adding topical therapy with silver sulfadiazine or mupirocin, bacitracin, retapamulin, if you see impetigo is also present. For care of the wounds, then you use baths and compresses to debride the wounds. And then you can consider water and electrolyte replacement if the patient is severely ill. Moving on to our second condition today, necrotizing subcutaneous infection. So I think most of us have encountered this in surgery where we've seen necrotizing fasciitis, and we know that it's usually a mixed infection. So the primary focus of this infection is in the dermis, the adipose and subcutaneous fascia. And then you end up with extensive necrosis and accompanying cellulitis. And the issue with this is that in as much as it's usually localized to extremities and the perineum, it can be life-threatening. The people who are at risk of getting this infection are diabetic patients and patients who've undergone surgical procedures. Culprit organisms include beta hemolytic group A streptococci and staphylococci, Aeromonas, Vibrio vulnificans, and other anaerobes. Most of the times, cultures may not grow an organism. So here's an image showing you what you're likely to see. This is an extremity, the lower limb. And I've said also the perineum is commonly affected. So you'll see erythema, and then this dusky discoloration. And then the limb will have a woody induration. It will be hot and tender. And then initially, the patient will report pain that is out of proportion with what you're seeing on physical examination. They may then develop bullae, which you've described already, and necrosis. And then they may have crepitus. Systemically, they may have fever and other constitutional symptoms like headache, vomiting, and as the disease progresses, they're likely to go into septicemia. How do you investigate for such a patient? Pus swabs, which I've said are often negative. So your diagnosis is clinical. In capable centers, you can consider doing an MRI or a CT scan of the affected area, and it will show you edema along the fascial planes. But normally in our setting, we explore surgically and we come up with a diagnosis intraoperatively. When it comes to treatment, seeing as they are more likely to go into sepsis, ideally you should manage this patient in an ICU setting, then surgical debridement on the affected area, and then repeated every 2 to 3 days. You should use a broad spectrum antibiotic that covers for both gram-positive, gram-negative, and anaerobic organisms. And also consider your culture and sensitivity report. Another significant condition to consider that is bacterial in nature is meningococcemia. So this condition is caused by Neisseria meningitidis, which currently for most of the world, vaccination is still ongoing. So the incidence is going down, but outbreaks do occur in communities, mainly due to nasopharyngeal carriage. And in as much as it's not a dermatological disease, the rash is characteristic. And when you see the rash, you should be able to at least save the patient's life. So the serogroups that are associated with 90% of the disease are serogroups A, B, C, W135, X, and Y. Children less than 10 years are more likely to be affected. And then they present with symptoms of meningism and altered sensorium, fever, malaise, headache, and joint pains. Then the rash will be, you'll see more of papura that initially will not be generalized, but with time spread to the entire body. Then with time, they have angulated markings, hemorrhage, and bullous formation. And then you may end up with necrosis. So this is the classic description: stellate papura with typical gunmetal gray central hue. As you can see in this image, this patient now has a fulminant petechial rash. These are petechiae, as in there's bleeding underneath the skin, and the stellate, they appear like stars. The edges are not smooth or rounded, they appear more angular. So if you are to investigate a patient who you're suspecting has meningococcemia, you should, of course, do your complete blood count, which shows a polymorphonuclear leukocytosis with burn forms and thrombocytopenia. And then you should also do your coagulation profile because DIC is highly likely in these patients. Your inflammatory markers will be elevated. In urine, you'll see proteinuria and hematuria. And then your blood cultures will show you the culprit organisms as well as the sensitivity pattern. But diagnosis is confirmed by isolation of the organism from blood or from CSF. And also it can be diagnosed via PCR. You've diagnosed your patient with meningococcemia. How do you manage it? ICU, circulatory support, IV fluids. IV benzyl penicillin is the treatment of choice in high doses initially, but if a patient has an allergy or for some reason you can't access benzyl penicillin, then you can consider ceftriaxone or cefotaxime. For relatives or healthcare workers who've been exposed to such a patient without proper PPE, then prophylaxis is mandatory. You give rifampicin for 2 days, and you ensure clinical monitoring so they also don't go into meningococcemia. Vaccination is also recommended. Okay, final bacterial condition is toxic shock syndrome. It's now rare, but when it was at its peak, we know there are 2 types of them. There's the menstrual toxic shock syndrome and the non-menstrual type. So the menstrual type has lower mortality compared to the non-menstrual type, mostly because it's easier to identify it early and it's associated with staphylococcus. Then the non-menstrual type is mostly seen like in burns patients or post-operative patients or patients who are post-delivery. And The streptococcal type is associated more with invasive soft tissue infection. The people who are at increased risk of toxic shock syndrome are patients who have cellulitis, underlying HIV or internal malignancy, alcohol abuse, and diabetes. You can see all these conditions basically cause immunosuppression. So they'll present with acute onset fever and rash, vomiting and diarrhea. And then they'll go into circulatory shock, which will not respond to IV fluid therapy. And they'll also have an AKI. Multi-organ failure will soon follow. So for you to diagnose a patient with toxic shock syndrome, you should have at least 3 systems involved, of which these are the gastrointestinal, renal, hepatic, CNS, muscular, and hematological. So the image here shows the typical presentation of a patient with toxic shock syndrome. They'll present with this sunburn-like rash that is characteristic. Then in terms of the GIT system, they'll have vomiting, they have this diarrhea, CNS, they have a headache, they have confusion. And then in terms of the membranes, they'll have non-purulent conjunctivitis and a sore throat. And they end up with sloughing of the skin desquamates from around the 3rd day to the 7th day, but from day 10 to 21, then it usually starts regenerating. And then from history, you will get history of either tampon use or menstruation for the menstrual type. And for that non-menstrual type, then you'll consider history of surgery, history of recent delivery, or history of burns. In terms of investigations, blood cultures will show you that this patient has either staphylococcus or streptococcus that is producing these toxins. And then management is hemodynamic resuscitation and IV antibiotics, preferably IV clindamycin, and with or without benzyl penicillin or vancomycin. For severe cases, you may consider intravenous immunoglobulin at the doses indicated here, but you should always look for the cause of the TSS. So moving on to the viral infections, we have eczema herpeticum, which is a condition which mostly affects children. And it's also known as Kaposi varicella-form eruption, caused mainly by herpes simplex virus type 1, but also may be caused by type 2. Transmission is by contact, that is fluid from a person with active herpes infection going onto a susceptible host. How do these patients, what puts them at risk of getting eczema herpeticum is impaired skin barrier function. So mostly these patients will have atopic dermatitis, but also they may have burns or irritant contact dermatitis, pemphigus, and all these other conditions that I've listed here. So in terms of presentation, the patient presents with a monomorphic rash that has erythema. The rash has vesicles that are umbilicated. I'll show you a picture on the next slide, measuring 2 to 3 millimeters. And then in the end, you end up with hemorrhagic crust. They also have systemic symptoms. They'll have fever, malaise, and then you'll note tender regional lymphadenopathy. If untreated, complications include secondary bacterial infection, bacteremia, and blindness. So these are what I was talking about when I was talking about the umbilicated vesicles. Here you can see there's punched out erosions in an infant, and then you'd expect to see tender regional lymphadenopathy in this area. Here, this is a patient who most likely has atopic dermatitis and then now has hemorrhagic crusts in the popliteal fossa. So diagnosis will be clinical, but also this Zank smear is a bedside test that you can do to confirm the diagnosis, to show you multinucleated giant cells. PCR is the gold standard of diagnosis if you have it in your setting. Viral culture may take a while to come back, and then you can also use direct fluorescent antibody. How do you treat these patients? Immediately you identify the infection, initiate antiviral therapy. You can use either oral, acyclovir or valacyclovir for 10 to 14 days. You prefer the second option because it's BD dosing as opposed to acyclovir, which has dosing 5 times in a day for oral therapy. Then when it comes to IV antivirals, when do you use it? If your patient is on oral therapy and deteriorating, switch to IV therapy. If they're unable to take oral therapy, or if they have severe disease, or if they're immunosuppressed. Other antivirals that you can use are foscarnet and trifluridine. Then when do you consider using antibiotic therapy? If you have confirmed that there's superadded bacterial infection. So you can use empiric therapy as listed, cephalexin, doxycycline, clindamycin, but you should base your antibiotic on culture and sensitivity. always be aware that you need to treat the underlying skin condition that caused the impaired barrier function of the skin. Then you should ensure appropriate wound care and early ophthalmology consult, because if the patient has herpes keratitis and it goes untreated, it can lead to blindness. Moving on to drug reactions. I've listed here the various drug reactions that you can have. So as you can see, the one that has a more immediate effect is urticaria or anaphylaxis, which usually starts on the day when the patient takes the medication and should resolve within 24 hours ideally. Then we go to eczematic drug reaction, which goes from 1 week to 2 weeks. Stevens-Johnson syndrome and toxic epidermal necrolysis, which may go from 1 week to 3 weeks. Then we go to DRESS, which from 2 weeks to 6 weeks after the patient has been initiated on the culprit drug. And then we have AGEP. I'll discuss all of this in detail in an upcoming slide. So beginning with Stevens-Johnson syndrome and toxic epidermal necrolysis, these two are a continuum of the same disease. So you have a severe mucocutaneous drug reaction, meaning it affects both your skin extensively as well as your mucous membranes extensively. And then the patient ends up with erythema, blisters, and sloughing of the skin. Common drugs that result in SJS and 10 in different patients are sulfur antibiotics, sulfasalazine, allopurinol, tetracyclines, anticonvulsants, mainly carbamazepine, lamotrigine, phenobab, and phenytoin. And then you also have NSAIDs, nevirapine, the ARV, and thiacetazone. Then rarely you can have an infection due to Mycoplasma pneumonia causing SJS and 10 in children. How do you define SJS? It's when the skin that has desquamated is less than 10% of the body surface area. If it's more than 30%, it's 10. And if it's between 10 and 30%, that's the SJS 10 overlap. How do your patients present? So following intake of the drug, they may present 7 to 10 days later, but up to 28 days after intake of the drug. They come with malaise, fever, prostration, and symptoms of an upper respiratory tract infection. Then the rash will start from the face and the chest and then spread peripherally. And it can even involve the palms and the soles of the feet. You see dusky to purpuric macules or atypical targets. I'll show you what atypical targets look like in an upcoming image. And then they also form flaccid blisters. Then the lesions progress rapidly and they may coalesce to form sheets of erythema. Another thing you're seeing again is painful skin. I told you that is a red flag. And then Nikolsky sign is positive. Mucosal involvement can sometimes precede skin lesion. The eyes, the mouth, and the genitalia are usually an early feature and lead to painful, erosive, and hemorrhagic mucositis. So this is the mucositis I was talking about. We're saying hemorrhagic mucositis of the mouth. This patient also had hemorrhagic conjunctivitis, sorry. And then this is what a target typically looks like, right? So if you look at this skin lesion, this one looks like a target, but this one has this dusky central area and surrounding erythema. So this is what we call an atypical targetoid lesion. It's not a typical target. It's just imitating what a target would look like. And this is what SJS and 10 looks like. This is another condition known as erythema multiforme. So you've identified your patient, you suspect they have SJS and 10. The next thing you do is you do a prognostic scoring. So this is the prognostic score known as score 10. 1 point for age more than 40 years, 1 point for heart rate more than 120, another point for cancer or hematologic malignancy, another one for body surface area more than 10% on day 1. And then you also check your urea level. If it's more than 10 millimoles per liter, that's another point. If your serum bicarb is less than 20, that's another point. And if your serum glucose is more than 14, that's another point. So as you can see, the mortality rapidly increases, so that by the time you're at a score of 5 and above, unfortunately, your mortality rate is at 90%. What do you do when you identify that your patient has SJS and 10? You withdraw the culprit drug or whatever drug you suspect is a culprit. And then management is multidisciplinary. You've said it affects not only the skin, but also the mucous membrane. So you want to involve your ophthalmology guy, you want to involve urology, you want to involve gynecology. Then if the epidermal less is more than 10%, then you want to admit into a specialized unit. In our setting, you tend to admit them mostly into burns units, and you pay particular attention to a heated environment and fluid replacement. You want to ensure a high protein diet, adequate analgesia, and treat or prevent any infections. Analgesia may include opioids like morphine, especially when you're dressing. And then skincare includes daily bathing, normal saline soaps, which may be found soothing by the patient, Vaseline gauze dressing, and aspirate large blisters which have intact ropes. Also, you want to care for your mucosa by examining regularly for any new onset of hemorrhagic lesions. And then you want to ensure oral hygiene using a mouthwash. You want to remove any debris in the oral cavity and the nasal cavity, artificial tears for the eyes, antibiotic drops, dressing, and lubrication for any vaginal erosions. If your patient goes into acute respiratory distress, at the earliest sign of it, kindly intubate the patient and ensure ventilator support. You also want to protect the gastric mucosa using a PPI, and you want to put the patient on a low molecular weight heparin to prevent any DVT occurring. So in case second line therapy is immunosuppressive therapy. So you may choose to use a systemic corticosteroid like prednisolone or pulsed methylprednisolone, but other options include IV immunoglobulin and cyclosporine. And you should remember to never start the offending drug in that particular patient, even after they have healed. And you should also remember that anticonvulsants can cross-react. So phenytoin, carbamazepine, and phenobab can cross-react. So I've mentioned all this about SJS and 10, about the confluent lesions, and about SJS being less than 10%, but 10 being more than 30%. But what you need to know is that there's a condition known as erythema multiforme, of which I showed you the typical target lesions, but you should also know that they can be papular atypical targets. And SJS and 10 tends to start on the face and then spread peripherally in the trunk, but erythema multiforme will mostly start on the extremities. How do you differentiate erythema multiforme minor from major? In major, there's involvement of the mucous membranes. And another difference between erythema multiforme and SJS and 10 is that erythema multiforme is mostly caused by infection, mostly herpes simplex viruses, but also mycoplasma, rarely caused by drugs. We now move on to DRESS, drug rash with eosinophilia and systemic symptoms. This is an idiosyncratic drug hypersensitivity reaction. And basically, you have the drug rash, you have eosinophilia, and you have systemic symptoms. But you can have DRESS and not have the rash and not have eosinophilia. So I'll show you how to diagnose DRESS. But you should know that the causative drugs are mainly anti-epileptics, which you've seen before, sulfur drugs, which you've seen also before. Also, a drug that most of us tend to think is quite innocuous is omeprazole, right? Allopurinol and ibuprofen. So the patient will present with fever, systemic upset, and lymphadenopathy. The rash will start on the face and the trunks, and then become eczematous or mobiliform that is generalized. They have vesicles, tense bullae induced by dermal edema, as well as follicular and non-follicular pustules, erythroderma, and purpuric lesions. So this is how you diagnose DRESS. There is this system called the Regiscar scoring system, and whenever you get a point for one that's indicated as Y, you put your score there, and then you have your diagnosis of DRESS, even if you have no rash and you have no eosinophilia. How do you manage DRESS? Mainly supportive. You should also withdraw the offending drug. You may choose to initiate a steroid orally or IV. And if this fails, you can consider other immunosuppressive therapy like cyclosporine, cyclophosphamide, rituximab, or ganciclovir. And the offending drug should never be restarted. Another drug reaction is acute generalized eczematous pustulosis. This basically means that the fact that it's acute means it occurs within 2 to 5 days, right? And then it's generalized all over the body. There's eczematous which generally means just it appears more like a viral rash, and then pustulosis. As you can see here, there are all these pustules all over the skin. So it's a severe cutaneous reaction, but it's usually self-limiting. And the important thing is to withdraw the offending drug. A list of offending drugs include aminopenicillins, quinolones, chloroquine, hydroxychloroquine, sulfonamide, sildenafil, and diltiazem. And then patients present with fever, non-follicular pustules, and then these tend to coalesce and form sheets of pus. Sometimes they can follow infection or spider bites. So I've talked about this 2 to 5 days after the intake of the suspected drug, and then they come in with skin itching and then non-follicular pustules, especially on flexural areas. And then they also have systemic involvement with fever, mild renal, hepatic, and pulmonary involvement. Management, as with all the drug reactions we've talked about, withdraw the offending drug. Then you can start an oral or a topical steroid, and then you should avoid restarting the drug in future. The lesions will resolve with time. We now move on to erythroderma. Erythroderma by itself is not a diagnosis. It just means that you have an inflammatory skin condition that is covering 80 to 90% of your body surface area. And it usually shows that there's an underlying skin condition. So when you have erythroderma, as well as scaling of the skin, as you can see in this image, we call it exfoliative dermatitis. The patient will also have fever and chills, malaise, pruritus, and they may also have hepatomegaly, lymphadenopathy, and peripheral edema. These are the causes of erythroderma. So we have eczema, that means atopic dermatitis, seborrheic dermatitis, and allergic contact dermatitis. Can also be due to psoriasis, can also be due to malignancies like lymphoma, leukemias such as cutaneous T-cell lymphoma, Hodgkin's lymphoma, and non-Hodgkin's lymphoma. Drugs, you can see again, the anticonvulsants, phenytoin, carbamazepine. Then also phenylbutazone, gold salts, lithium, and cimetidine. Also pemphigus foliaceus, hereditary conditions like ichthyosis, and other skin diseases like lichen planus, dermatophytosis, encrusted scabies, and dermatomyositis. But it can also be idiopathic. So why are we concerned about erythroderma? It's because it can be fatal. You see, the mortality can go up to 64%, which is quite high. And the causes of mortality are cutaneous infection, sepsis, and pulmonary infection. Patients also end up with hypothermia, and they can end up with a high output cardiac failure, especially in elderly patients who are also having underlying cardiac conditions. And then in the long term, they can end up with ectropion, diffuse alopecia, keratoderma, and nail dystrophy. How do we manage erythroderma? Initially, we want to admit the patient to hospital because it's an acute disease or an acute flare-up of a known disease. So you want to withdraw or switch any medications that you suspect may have caused this erythroderma. You want to monitor and correct fluid and electrolyte loss, and also control for temperature instability. We'll talk about this in another slide about how to ensure temperature control when it comes to nursing care. Then treat any secondary infection, nutrition and vitamin supplementation, mainly because your skin has an impact on vitamin D synthesis, sedative antihistamines, and frequent application of greasy emollients. Then for second line therapy, you want to do systemic therapy dependent on the underlying cause. That means that you may choose to use immunosuppressants, but you want to avoid, let's say, steroids in psoriasis. Skin failure syndrome. So why would we call it skin failure syndrome? It's because your skin is the largest organ in your body. And being the largest organ, it has various functions. Apart from the mechanical functions, it also has immunological and endocrine functions, and it serves to maintain body homeostasis. So if you have any alteration of function in your skin, it could basically affect your internal organs, and mainly these are the kidneys and the heart. So what are the consequences of acute skin failure syndrome? You end up with fluid and electrolyte imbalance, protein and calorie loss, impaired thermoregulation, alteration in immunological function, infection and sepsis, endocrine, that is vitamin D deficiency. Systemic abnormalities include malabsorption, cardiac failure in people with poor cardiac reserve, and renal failure. what will cause skin failure syndrome. It could be idiopathic, but the known common causes include SJS-N10 and Erythroderma, which you've discussed previously, acute generalized pustular psoriasis, pemphigus, either pemphigus vulgaris, foliaceous, or paraneoplastic pemphigus, staphylococcal scalded skin syndrome, dermatitis, either atopic, seborrheic, or contact dermatitis, also febrile viral exanthems, exfoliative drug rashes, pityriasis rubra pilaris, cutaneous T-cell lymphoma, and graft versus host disease manifesting in the skin. How will you manage a patient who you suspect to have acute skin failure syndrome? You want to ensure adequate oral intake. If your patient can't feed orally, you can consider putting in an NG tube to ensure adequate feeding. Then you also want to put in a large bore IV cannula through unaffected skin. You want to maintain an input-output chart on a daily basis. And you also want to check your vitals, including the pulse oximetry. What investigations will you do for this patient? You start with your basics, a complete blood count, your inflammatory markers, CRP. You want to do your renal function test, your liver function test, your fasting blood sugars, your serum proteins, which are likely to be low, and PASOB from multiple sites. So when you're resuscitating this patient initially, especially in the first 24 hours, IV fluids should be given according to the extent of skin involvement. And you want to ensure electrolyte imbalance is corrected as early as possible. And then if you're saying your patient has 80 to 90% of their skin in failure, so how do you ensure that the temperature control in the room is adequate? You want to nurse them at 30 to 32 degrees Celsius so that you prevent shivering, because whenever they shiver, they're spending a lot of their calories on production of heat, which leads to further weight loss. And you also want to use humidifiers to maintain your room in a humidified state. If you don't have a humidifier like in our setting, you can consider maintaining a boiling kettle near the room. If you suspect infection, you initiate IV antibiotics. That's a bone of contention because some say you should confirm that infection is present before you initiate your antibiotics. Then gentle handling of the skin. You should ensure strict barrier nursing, so that whoever is nursing the patient does not transfer infections from their own skin onto this fragile, damaged skin of the patient. And then in terms of any erosions that are present, you want to wash with normal saline and apply Vaseline, gauze dressings, and other wet dressings. Once your patient is stable, then now you can look for the underlying cause. But if you suspected a drug from the start, you should have withdrawn it from that moment. You should always consult dermatology early in the setting of skin failure syndrome. And then after they have left the hospital, kindly ensure that you have enrolled them into a dermatology clinic. Our last condition of the day is autoimmune diseases. These are the immunobullous diseases, of which the prototypes are pemphigus vulgaris and bullous pemphigoid. So we'll start with pemphigus, which is a condition that is mostly seen in younger patients. And this is an image of what pemphigus looks like. So you'll basically see your patient coming in with flaccid bullae, and these ones tend to rupture easily. So you may see your patient coming in with more of ulcers and superficial erosions as compared to the blisters themselves. How do you confirm that you're dealing with pemphigus vulgaris? Number one will be Nikolsky sign, which will be positive. And of course, your biopsy will also guide you. Prognosis is generally poor for pemphigus vulgaris. When it comes to bullous pemphigoid, these ones are subdermal. So they tend to be tense blisters, as you can see here, and they're very firm. Nikolsky sign is negative, but the prognosis for these patients is favorable. How will you manage a patient who has immunobullous disease? So you should be careful to rule out infection. And then systemic steroids are the mainstay of treatment, but you may choose to go for steroid sparing therapy. So I've listed the drugs here. You may choose to use prednisolone at 0.5 to 1 mg per kg IV, which is a high dose, or you may choose to pulse methylprednisolone or dexamethasone. Steroid sparing therapy includes azathioprine, cyclophosphamide, mycophenolate mofetil, IVIG, and rituximab. Then in terms of nursing care, you want to manage as acute skin failure syndrome. You want to ensure oral and eye care. You want to ensure daily bathing and want to soothe the skin with saline soaks and aspirate large bullae which still have intact roots. Then ensure a high protein diet and supplement your vitamins. Systemic antibiotics, as we've said before, in the setting of infection and guided by culture and sensitivity. So that's it for my presentation. Thank you for listening. And these are my references. I will now invite any questions.
Thank you so much, Dr. Vaidera, for that well-researched and brilliant presentation. I will go through the Q&A, see if there are any questions pertaining to your presentation. There's one question: is exfoliative erythroderma the same as erythroderma? And then the most common skin condition, like a fungal infection. I can't see this very well. But KNH is usually negative. So maybe you can start with those two as we get more questions for you.
Okay, so I'll start with exfoliative erythroderma versus erythroderma. We said erythroderma basically means that 80 to 90% of your skin has the inflammation. Basically, you'll see redness. But when you talk of exfoliative erythroderma, we are saying there's also associated scaling and desquamation of the skin, which should be a red flag for you. I don't know if you have anything to add, Dr. Kavete.
No, I think that is well answered. Thank you. So for the initial fluid resuscitation, do you use the Parkland formula?
I think we do. There are various guidelines, various national guidelines which give differing opinions, but in our setting, we mainly use the Parkland's formula.
All right, thank you, Karen. So there's one very important question which says, how do you confirm the offending SJS?
I think for that question, let me share something. As I'm looking for it, the thing that will mainly guide you as to what is your culprit drug that is causing the infection is, number one, your timeline. So you want to establish a drug timeline, which drug was started when, and when did the rash start? And then once you've done that, then you'll have your answer with you. I'm looking for an image to share with you.
Have you found it, Karen?
Just a few seconds, I'll have found it. Okay, I have. Okay, so if you look at this, drug chart, we have a patient who has been on several drugs, And we can see the patient has been on vancomycin, has been on cefepime, levofloxacin, phenytoin, and NSAIDs. And the rash started on this particular day, and you are called for a consult on this day. But if you look at your drugs, you can be able to tell what caused this drug rash, because this is the drug that has been there for quite a period of time. So in this case, we'll think of cefepime as our culprit drug, and this is a mobiliform drug. I don't know if this helps to answer the question.
Yeah, that helps quite a bit. And also, the attendants should remember to take a very detailed history, because in our setup, most patients do go and buy drugs over the counter. Sometimes they don't even know which drug they have been taking. So you might need to delve into the history, maybe even corroborate the history with the relatives, so that if they need to go back to maybe a previous hospital that they were at, or a chemist that they had gone to buy the drug, all those things will help you identify the culprit drug. All right. So I'll go to the rest of the questions. The other question is about steroids. Do you think, since steroids have a side effect of delayed wound healing, do you think they are useful in this condition? Also, when you compare between peripheral catheters versus central catheters, what is your comment about that and the infection rates? Maybe you can answer those two first.
Wow, okay. I think the reason why people, we know steroids tend to come with a lot of adverse effects, but the reason why steroids are preferred in most of these inflammatory conditions, save for psoriasis, is that they tend to have an early onset of action. So in this case, your patient is presenting in an emergency situation with desquamation of most of their skin surface area. You want to ensure that you have halted whatever is causing progression of the skin disease at an early stage. Then once you're able to switch to another therapy that is not your high dose steroid that has less side effects, you can do that. I think I'll ask for help for the second question from you, Dr. Kabet.
Okay. All right, so it depends on the situation that you find the patient in. If they have more than 70 or 75% total body surface area involved, you might need to use a central catheter, because depending on the condition they have, if the condition is giving them generalized exfoliation, or if the Nikolsky sign is positive, it will be difficult for you to use a peripheral catheter. So you have to make that decision based on how the patient looks. The other thing I wanted to comment about is the SCOR-10. It's a very good tool to prognosticate the patient, but remember to do it every day. As you do your rounds every day, make sure you're doing the SCOR-10 every day, and this will give you a good indication of whether your patient is improving or not. So for people with drug reaction, does that mean they should avoid the drug forever? I think Dr. Karen answered that one because of the body's, the body will remember that you had taken the drug. And when you take the drug again, the reaction will even be more severe than what you had initially. So the patient should avoid the drug forever. You should give them some form of documentation, whether it's a card, whether it's a wristband, or something that they need to carry with them, so that in future, nobody will prescribe that drug to them. So there's another question about, is there any particular quantity of medication that may act as a threshold to the drug reaction? For instance, is one tablet enough to warrant as an offending agent? Karen?
I think it depends on the particular drug reaction that we're speaking about. For example, when it comes to a drug reaction like AGEP, one dose or even 2 doses is adequate for that. But when it comes to, and even with urticaria and anaphylaxis, but with the other drug reactions, you need exposure over a period of time.
All right, that is true. Also remember the drugs that Dr. Karen has mentioned, the anticonvulsants, which usually share what is called an aromatic ring. And you can give phenytoin today, and then tomorrow you give, what's the other one called? Like phenobarbital, and the patient will react. So in that case, if you're having a patient who requires anticonvulsants but has reacted to that group with the aromatic ring, you need to look for another anticonvulsant for them, which is outside of that group. All right, so there are many questions. I'll just go to the ones that pertain to this talk. Which topical drug is best to dress skin eruptions in SJS? Karen?
I'll revert that to you, Doc.
Okay, all right, I can help you there. So basically, in SJS, we try to avoid anything with sulfur. So you may pick any of the other antibiotics. So avoid damazine, which is very common to us, which is silver sulfadiazine. So you may use a cream base. So like fusidic acid, or you can use any of the dressings that have antimicrobial properties to dress. All right. Okay. So we can go to the participants who are raising their hands. Let me just unmute them.
Nelson, can you unmute other participants to ask questions as we move forward? Nelson, are you able to do that? So, Doc, there's also another question is, what is your advice to a patient who has allergy to the sun and feels itchy to where the sun touches? Dr. Karen?
I don't think that pertains to our topic of the day, but I think they should seek dermatological consult because they may be suffering from photosensitivity, either due to a drug they're currently taking. It could even be a supplement they're currently taking, and they're at risk of post-inflammatory hyperpigmentation.
Thank you, Karen. We'll have Mr. Odio to ask his question.
Thank you very much. I think this is a wonderful presentation, and I've really enjoyed it. As an obstetrician gynecologist, we see quite a lot of these conditions, and it is important that you have given us such highlights. My only question is more of public health question. As we look at our counties, how many dermatologists do we have in the counties to be able to support these processes? Because I know you are describing a process where there are quite a number of you within Nairobi, but I don't know how we can be able to help the patients outside the Nairobi area. Thank you.
Okay. I think most of this question will be answered by Dr. Kavete, but the part where I can contribute is I read a newspaper article, I think last year, which said there are only 32 dermatologists in the country. So maybe training can also assist with that. If we had a local MED program, that would really assist. And also we have clinics that run, for example, we are based in Odaya and there's a clinic that runs there every Tuesday and Thursday. So most of the patients that are seen there, I've noticed are referrals from the entire region. Dr. Kabete.
Right. Thank you, Karen. Thank you, Mr. Odongo, for that pertinent question. Basically, training is what is going to help us. Currently, there's an organization for a local training between KNH and JK-UoN. So that is to come in the future. Another avenue that can be used is telemedicine or teleconsultations between the people in the counties and and the dermatologists in Nairobi and its environs.
Thank you.
All right, we'll go to another question from Billy Lubanga. Billy, are you able to unmute your microphone and ask your question? Fidelis Mwasa, kindly unmute your microphone. All right, let's ask questions for those who can be able to meet. Yes, Fidelis, go ahead. Fidelis?
Hello, good afternoon.
Good afternoon, go ahead. Yes.
Yeah, I had a question pertaining nappy rash whereby the condition turn septic. What can we really, what is the best way to manage the condition for nappy rash whereby it is turning septic? Hello.
Yes, we can't get your question, but you can type on the chat box. We'll be able to pick it up.
Okay.
Okay. Ruth Karimi? Ruth Karimi, can you go ahead and ask your questions? Okay. John Gatabaki, can ask your questions. Yes, there's a question on the chat box. Does isoniazid cause 10 or generally anti-TBs? Dr. Karen.
I don't have much experience with anti-TBs and 10. Maybe Dr. Kavete can help us with that one.
Thank you, Karen. It's hard to say whether it causes 10. Sometimes the ones I've seen is that they cause some form of exfoliative dermatitis, and isoniazid and rifampicin are actually even ethambutol are part of the anti-TBs that cause cutaneous drug reactions. So, and since they're given as a combination, you have to generally use some sort of a chart. And when you want to reintroduce the patient back to them, you start with one at a time so that you can sort of ascertain which one of them was giving them the reaction. Okay, others are talking about the CPDs. I think the Secretariat will share. And also there are other questions on whether we can share this presentation. I think we are going to share it on email. With that, I think we can bring this to a close. I'll give back the mic to Ken Okinda, and mine is to thank all the participants for attending and listening, and also Dr. Karen for giving such a brief. Ken?
All right, thank you very much for our two facilitators for the good presentation that we've had. We also want to thank the participants for your active participation. From the comments, from the chat box, I can see we were very actively following the presentation. And we look forward to have more of these presentations, especially pertaining dermatology area. And as one of the participants has pointed out, the issues to do with spread up of dermatological services to the far-flung areas within the country and also around the world. I think with that, many participants who have joined will be able, there are those who are dealing with policies and they'll be able to do something pertaining that. In regards to CPD points, yes, after this presentation, we'll be able to dispatch consultants and also the pharmacist. So for nurses, we urge you, like once you've received your CPD points, you kindly upload it within 48 hours. That will be enough for you to get your points. As for the presentation, we'll also find a way of sharing to the participants on your respective email addresses. I would like to end it there, unless there's a burning concern. I want to say thank you. Kindly don't miss to check our CME, our forthcoming webinars. Currently, there's one that we'll have tomorrow, Wednesday, on safe maternal care. So look at addresses for this. You can still also watch the previous webinar sessions. When you log into our website, you just click on the webinars tab. You'll be able to numerous webinars that we've held since we've started the program. So you can be able to get up to date on the areas that you need to get knowledge on. Otherwise, I want to say thank you for this. Looking forward for more of these webinars from our various cadres and from our various doctors. Thank you, and have a lovely day, lovely evening, wherever you are. And for those who are outside the country, have a lovely night and morning. Thank you. To another day.